Hello, everyone. Thank you for joining us today for our webinar entitled Leveraging the New Billing Code for Chronic Care Management. Today's presenters are Kelly Schoenhart, MCEDA Regulatory Analyst, and Dr. Stephen Aris Jr., MCEDA Clinical Advisor. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for Kelly or Stephen, please type it into the questions box in your GoToWebinar interface. We will take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will also be posting a recording of today's webinar and a copy of the presentation slides on our website, mceda.org. Go to www.mceda.org. Hover on the Resources tab, then select Webinars. The information presented in this webinar is current as of today and is only intended to be a general summary. As policies change frequently, we encourage participants to review the specific statutes, regulations, and other interpretive materials for a complete and accurate and current information. With that, I will turn things over to Kelly.
Thank you, Liz. Good afternoon, everyone. Thank you for attending today's webinar on leveraging billing code for chronic care management services. A little background information. Section 103 of the Medicare Access and Chip Reauthorization Act of 2015, also known as MACRA, codifies payment broadly for chronic care management services under the physician fee schedule for services furnished on or after January 1st, 2015 by physicians and non-physician practitioners that Medicare generally recognizes to furnish and bill evaluation and management services. Our presentation today will focus on the numerous requirements that must be met in order to bill for chronic care management services. Chronic care management services provided to Medicare beneficiaries with 2 or more chronic conditions which place the patient at significant risk of death, acute exacerbation, decomposition, or functional decline, and are anticipated to last at least 12 months or the extent of the patient's lifetime, may be billed using CPT code 99490. Chronic care management services may be billed by physicians, certified nurse midwives, clinical nurse specialists, nurse practitioners, and physician assistants. Chronic care management services will be billed most frequently by primary care providers. However, specialty practitioners who meet all the requirements may also bill for services. Additionally, chronic care management services are not within the scope of practice of limited licensed physicians and practitioners, such as podiatrists or dentists, so they may not bill for such services. Chronic care management services may be billed using CPT code 99490, which is defined as non-face-to-face care coordination services provided to Medicare beneficiaries, which consist of at least 20 minutes of clinical staff time directed by a physician or other qualified healthcare professional per calendar month. These services may be provided directly by the eligible practitioner, by consultants, subject to the Medicare Physician Fee Schedule Incident 2 rules and regulations and all other Medicare rules, or by clinical staff incident to the billing practitioner. CMS provided an exception that allows the services to be billed under general rather than direct supervision of the eligible practitioner. However, this exception does not extend to services provided in rural health centers or federally qualified health centers, which we will discuss later in the presentation. CMS requires the billing practitioner to furnish a comprehensive evaluation and management visit, an annual wellness visit, or an initial preventative physical examination to the patient, and to initiate the chronic care management service as part of this visit or examination prior to billing for chronic care management services. The face-to-face visit is not part of the chronic care management service and can be billed appropriately. And informed consent does not need to be obtained at this visit. It can be given subsequently. However, this is an opportunity for the practitioner to obtain patient consent. So the informed consent requirements are that the eligible professional must inform eligible patients of the availability of chronic care management services and obtain written agreement to have the services provided prior to furnishing or billing the services. So the eligible practitioner should actually explain what the chronic care management services entail and offer the services to the patient. They should document the discussion in the patient's medical record, noting the patient's decision to accept or decline the services. Obtain written agreement to have the services provided, and the agreement should include authorization for the electronic communication of medical information with external members of the patient's care team. And the eligible practitioner should also explain how to revoke the services. The patient consent agreement process should include a conversation with the caregiver and the patient in which the patient is informed of what chronic care management services entail, how the patient can access elements of the service, how their information may be shared with other caregivers, and also how the patient may be subject to copays and deductibles for chronic care management services. So although copays and deductibles apply, chronic care management services may avoid the need for more costly face-to-face services in the future by proactively managing the patient's health rather than only treating disease and illness. So this would be the time to present that information to the patient. The chronic care management service is expensive, and it includes elements such as the structured recording of patient health information, creating and maintaining an electronic comprehensive care plan, ensuring access to and the continuity of care, and care management services. CMS requires the use of certified EHR or other electronic technology in order to satisfy some of the chronic care management scope of service elements, which we'll discuss in the following slides. The structured data recording requirement for the chronic care management scope of service dictates the use of certified EHR technology to record patient demographics, problem lists, medication lists, and medication allergies in order to create a structured clinical summary record from the EHR. The care plan scope of service element requires a comprehensive care plan to be created and maintained electronically and available electronically at all times to anyone within the practice that is actually providing chronic care management services. The care plan should be provided electronically, which is other than by fax, as appropriate to external providers and practitioners, and the patient must be provided with either a written or electronic copy of the care plan. So the comprehensive care plan elements typically include, but are not limited to, those listed here on this slide, which are, the problem list, the expected outcome and prognosis, measurable treatment goals, symptom management, planned interventions, and the identification of the individuals responsible for each intervention, medication management, social and community services ordered, description of how external agencies and specialists will be directed and or coordinated, and then a schedule for periodic review and, when applicable, a revision of the care plan. Ensuring access to care by providing the patient with the means to make timely contact with healthcare practitioners within the practice who have access to the patient's electronic care plan to address his or her urgent chronic care needs is also a scope of service element. Additionally, continuity of care and enhanced communication opportunities for both the patient and any caregiver with the practitioner, of course in compliance with HIPAA, must also be provided. As you might expect, care management is another scope of service element, which includes an assessment of the patient's needs, ensuring timely receipt of all recommended preventative services, medication reconciliation, and medication management oversight. Additionally, care management transitions and care coordination are also part of the care management scope of service. As of January 1st, 2016, the chronic care management services may be billed by federally qualified health centers and by rural health centers, which will be paid based on the physician fee schedule, national average non-facility payment rate. There is no exception to the direct supervision requirement at this time for chronic care management services furnished by qualified auxiliary staff at FQHCs or RHCs. Thus, services furnished incident to require that the FQHC or RHC practitioner be present within the facility and immediately available to provide assistance and direction. Our presentation covered highlighted portions of the scope of service elements required to bill CPT code 99490. But for a complete listing of the CMM scope of service elements and the electronic technology requirements that must be met in order to bill for the service, we would recommend that you refer to the Medicare Learning Network Chronic Care Management Fact Sheet, which is the first item listed here. And as Liz previously stated, a copy of this presentation will be posted on our webinar, mceta.org. And so now I will turn the presentation over to Dr. Stephen Aris.
Thank you, Kelly. With more than 75% of healthcare spending going towards patients who have more than 2 chronic conditions actively diagnosed by either their PCP or their geriatrician, the healthcare community, society at large, was overwhelmed with the arrival of the billing code from Medicare back in January of 2015. The consensus was that Medicare had chosen to acknowledge the importance of chronic disease management by agreeing to reimburse for the time that is necessary to provide comprehensive care for these, at times, what can be overly complicated patients. That being said, there remains obstacles to meeting the requirements that are set forth by Medicare for all eligible providers. However, as MCETA has assisted with Meaningful Use program for the past 6 years by helping eligible providers navigate all of the requirements, the Alterum Institute is pleased to announce that starting in January of 2017, we will be assisting eligible providers with navigating the requirements set forth by Medicare in order to provide the service spelled out by CPT code 99490 and ultimately appropriately bill for it. What we hope to do is have a case manager contact the patients on behalf of the eligible provider and fulfill that 20 minutes of non-face-to-face time. In doing so, they'll be taking care of such responsibilities as a med reconciliation, ensuring the receipt of recommended preventative services, monitoring the health of the patients, not only physical, but mental and social as well, providing education and addressing any questions that may come regarding the condition and the patient's well-being from the family, the caregiver, and also reaching out to community resources who are involved in taking care of that patient. We're very optimistic about what this program can do for the providers we've been helping over the years, and hopefully we can continue to see success working together with all healthcare providers in the state of Michigan. At this time, we'd like to open the floor to any questions that may have come in.
We have had some questions. The first one is, do patients of an SQHC have to pay a copay or deductible?
Yes, there is a copay with the program. And the reason behind the copay is that we wanted to give patients the leverage to say that they are not either being satisfied or that the time being spent between regular appointments fulfills their expectations for an over-the-phone appointment, if you will. So by having the patient pay the copay and their willingness to do so is a demonstration of their appreciation of the service. So the $7.50 is the estimated copay for patients who consent to the service with their provider.
What does the written consent look like?
We can make the written consent available to all of our providers, but basically it is a consent that is informative of what the service provides and shows an agreement on behalf of the patient that they will be billed, and also clearly spells out what they are entitled to expect from the provider who has agreed to engage with the service.
We do have a few more questions. What role can a care manager play in CCM services?
What role can a care manager play in the CCM services? The care manager's role is invaluable. They have the experience of coordinating care outside of the acute setting. That being said, there are other members of the care team who can also fulfill these requirements. In doing so, they need to have an established rapport with the patient and be able to understand all of the components that go into managing a patient who has chronic conditions. But a care manager can very well address the scope of service as spelled out by Medicare.
What software is available to document CCM?
The beauty of the billing code 99490 is that no additional software is needed. As long as that practice is using an ONC certified EMR, they're good to go. They need to document that they had a patient encounter, the date, and the time that the 20 minutes were fulfilled, but there is no additional software that needs to be purchased or downloaded or implemented for that matter.
Would a Master's of Social Work be able to bill this code for coordinating with the PCP?
No, unfortunately, someone who has a Master's of Social Work would not be able to bill for this code. The PCP would be able to bill for the code if he or she had designated the person who has the Master's of Social Work to carry out these tasks. Then the PCP's office could bill for it.
What are the benefits of our practice using the new CCM service offering from our Alterum versus hiring our own case manager?
Well, Alterum's new commercial service offering allows providers to enjoy the added benefits of avoiding the financial burden that comes with hiring a new full-time employee, such as the salary, the benefits, and all of the other aspects of taking on a new employee. Furthermore, when you take on this person in your practice and designate them with the responsibility of calling these patients, the practice may not have enough enrolled patients initially. so their job may not be fully warranted initially. And since Alterum has an established HR department, the hiring and the vetting process is typically more developed than you'd find in a medical practice. And lastly, Alterum has the added benefit of finding employees through networking, whether it's referrals from industry colleagues, advisors, board members. We're an established organization in the healthcare industry, and we're able to reach out to that professional network to find people suitable to fulfill this role.
Are there CPT codes we cannot bill during the same service period as this new billing code?
Yes. Yeah, there are. Among the billing codes that you cannot bill within that same month would be a billing code such for end-stage renal disease, for example. CPT code 90951 through 90970. And the premise for that was that in order to appropriately treat a patient who has ESRD, you need to be coordinating care not only with the dialysis center, not only with the specialist who's the nephrologist, but that is expected when you're billing for the ESRD CPT codes. So in order to bill for that code and then to proceed and bill for the chronic care management code, Medicare feels that would be a demonstration of double dipping. ESRD involves additional time spent when the patient is not in the office. And that's the same thing that can be said for the transitional care management billing codes, 99495 and 99496, and also healthcare common procedure coding systems, which involve the home health care supervision codes and hospice care supervision. There are other codes, and for that I recommend consulting CPT instructions for a complete list of the codes that cannot be billed during the service period.
Do we need to have met meaningful use in order to take advantage of this billing code?
No. Your office does not need to have met meaningful use. However, your practice does, again, I need to reiterate this, your practice does need to be using an ONC certified EMR.
How much does CMS pay providers for code 99490?
CMS pays the provider $42.60 per patient who enrolls in the program. $35 will come from Medicare, and $7.60 will come from the copay of the patient.
You mentioned comprehensive services must be documented in the chart. Please give more information on this, such as when or how often.
According to the final rule, there is no specification exactly of what they would be looking for. However, that being said, we would endorse that the documents include the date and time of when the 20 minutes of non-face-to-face time was met, the location, and the findings of the conversation that were had during that phone call, such as any changes in their mental health, physical health, difficulty getting to appointments outside of the provider's office, or so on and so forth. But currently there is no explicit language indicating what needs to be in the EMR. Just we encourage date and time and what was discussed. A brief summary, if you will.
If a care manager is utilized, does he or she continue to bill for that service, or does the physician bill only?
Care manager. Yes, the physician can bill for a care manager calling or taking care of those patients, providing that service. But the care manager cannot bill independent of an eligible provider having attained a written consent from that patient. So that patient had to have agreed or signed a written consent that was furnished by by a physician or the mid-level providers that were mentioned earlier in the presentation. And upon doing so, they would be the ones to bill for the service, but the care manager could be the one to call and to document in the EMR.
If patients will not have the money to spare to the cost of the copay, are there any other options?
According to the final rule, the copay of $7 is necessary. An alternative to the $7 copay might be provider-based, but that would be a decision between the patient and the provider.
Additionally, part of getting the patient's consent to bill for CPT code 99490 is that only one provider can bill and be paid for the service on a monthly basis. And I kind of I forgot to mention that as part of the presentation. So getting their consent is required for that reason.
Okay, that is all of the questions we have for now. If we have missed anyone's question, we will email you directly with an answer shortly. As a reminder, we will be posting a copy of today's slides at www.mceta.org. Thank you everyone for attending and have a great day.